Hello, everyone. Welcome to my talk. My name is Luis, and I'm a BU medical student, and I wanted to present a project I have undertaken. So the project deals with looking at temporal lobe epilepsy and determining whether aura type can predict outcome following anterior temporal lobectomy. Let's start. No disclosures. So, a little background. Temporal lobe epilepsy is one of the most common focal forms of epilepsy. Typically on MRI findings, what you're looking for is mesiotemporal sclerosis, usually of the hippocampus. Now, this type of epilepsy is often medically refractory, and so we have to consider other treatment modalities in order to achieve adequate seizure control for the patients. Now, one thing that's important in this type of epilepsy is that it typically presents with auras. What auras are is that these are the preictal sensations that patients will feel before the onset of a seizure. And these can vary. These can range from a rising sensation in the stomach to intense feelings of deja vu to visual hallucinations. And our goal with the study was to see whether we can correlate aura type to outcome following surgery. Now, in order to do this, we retrospectively reviewed the charts of 203 patients who underwent anterior temporal lobectomy. All of them had at least 1 year follow-up, which was a requirement to enter the study. Mean follow-up was 6.31 years. And the primary outcomes we were interested in looking at were angle score. And angle score is a classification of seizure control following surgery, with Angleclass 1 being optimal seizure control. Change in medication, so number of antiepileptic medications a patient took before surgery compared to after surgery, and the reoperation rate. And reoperation rate refers to medically related surgeries, so epilepsy-related surgeries. So some demographic variables. Epigastric auras were the most common in our cohort, followed by mnemonic auras, and interestingly, 10% of patients denied having an aura. Now, when we looked at changes in antiepileptic drugs, we saw that overall patients did decrease the amount of antiepileptic drugs. The cohort on average was between 0.8 and 0.9, so almost 1, except patients with gustatory auras who had the smallest decrease in antiepileptic drugs in our cohort, suggesting that these the seizures in this cohort was less well controlled with surgery. Now, the reoperation rate for our patients was pretty low. It was somewhere under 10%. However, patients with affective auras had significantly higher rates of reoperation, so higher rates of medically or epilepsy-related surgery, close to 20%. Now, Angleclass relationships, this is a logistic regression that we conducted, and this evaluated aura type in addition to various demographic variables to see which of these was the best predictor of outcome. What we found was that cephalic auras predicted the worst outcome following surgery, and MTS or mesiotemporal sclerosis on preoperative MRI indicated a better prognosis for patients who underwent ATL. The number of antiepileptic drugs had a negative correlation with outcome. So the more drugs that you took, the worse your outcome. And this just summarizes the Angleclass outcomes by aura type. And so for our cohort, we were able to achieve close to a 70% Angleclass 1. And the auras that we've been speaking about, cephalic auras, just over 50% Angleclass 1, affective just under 50%. And gustatory auras, although these patients took more antiepileptic drugs after surgery, were still able to maintain somewhere in the range between 60 to 70% Angleclass 1. So in conclusion, cephalic auras are associated with worse Angleclass outcome. Gustatory auras had the lowest decrease in medications. Affective auras had the highest reoperation rate. So all in all, we took this to mean that auras are important to ask about in the preoperative workup and may be useful in selecting optimal surgical candidates. So we thank Matthew Thomas for his administrative assistance. Here's my email in case any of you need to contact me. And thank you for coming to my talk.